Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. Where do we go from here? That's the fundamental question that the National Academy of Medicine asked 8 years ago when, to mark the new presidential administration taking office in January 2017, the organization commissioned a series of forward-looking papers about the most compelling opportunities and priorities in health, healthcare, and biomedical science. They called the project Vital Directions, and they did it again in early 2021 as President Biden took office, publishing a series of articles in Health Affairs, laying out a broad agenda for policymakers to act in areas as diverse as infectious disease, addiction, and aging. Well, here we are 4 years later. It's time once again to take a look in the mirror. And while some may see a hot mess, it's also possible, maybe even necessary, to wonder if it's still reasonable and meaningful to take a broad and long view of health and healthcare in this moment. For the National Academy, the answer is undoubtedly yes. On January 21, the day after President Trump took office, it published another series of 6 Vital Directions papers in Health Affairs. They offer a series of detailed priorities for policymakers who care about the future of health and healthcare in America, with a focus on fields like AI, the biomedical enterprise, women's health, and healthcare payment and delivery. All of them come back to that same question from 8 years ago. Where do we go from here? And it's the subject of today's Health Podyssey. I am here with the one and only Dr. Donald Berwick, President Emeritus and Senior Fellow of the Institute for Healthcare Improvement, former administrator of the Centers for Medicare and Medicaid Services, and really one of the nation's leading authorities on healthcare quality and improvement. Together with a real dream team of co-authors, Dr. Berwick wrote a paper in the Vital Directions series titled From Laggard to Leader: Why Healthcare in the United States is Failing and How to Fix It. And I'm pretty eager to ask him all about it. Dr. Berwick, welcome to the program.
A pleasure to be with you, Rob. Thanks for having me.
So before we dig into some of your recommendations, I'm just really curious about how this all came together. What was your assignment from the folks at the National Academy of Medicine? How did they approach you? And I have to say, your co-authors are a pretty illustrious group too. How did you all come together to make this paper possible?
Well, the leadership of the National Academy, as you said in your introduction, have now regularized the publication of these vital direction guidance for new administrations, hopefully for new administrations as they come in. And so I was asked to take responsibility for overseeing the production of one of those papers on sort of healthcare reform. What are the system changes that are needed? I thought it was a timely and exciting request, and they did me the honor of letting me pick my co-authors, a wonderful group of colleagues who share with me a very intense feeling that things are not working now, that we have a failing healthcare system, and that the degree of failure is big enough that marginal changes aren't likely to work. And so I was able to assemble a group that met regularly for a couple of months to kind of chart out, well, what would be really a new pathway. Not an easy assignment, but it was really fun to work with this group. And we want to take a stand. And I think we've done it.
It does feel that way. Who would you say is the primary audience for this paper, and how did that shape your approach? I know you just mentioned the sort of target is a new administration, but is that really who you have in mind sitting down with the paper?
It's got to be everybody. I think one of the aspects of the failure we've seen is a failure of convergent strategy where different stakeholders come together around at least common goals and hopefully a common vision of the system we need. Without that kind of sense of everybody's got a piece of this, I don't think success is likely. But if I had to pick one audience, it would have to be policymakers. They're setting the stage. They're Congress, The federal government and state governments are setting the stage for what is possible or not. But it really has got to be everybody. The current players in the status quo, although we have a dissatisfied public, a dissatisfied group of in the payer community, the employers and the individuals that are paying out of pocket, and patients who really don't like what they're seeing right now, and that's a vast majority of the American populace. The incumbent corporate entities, the health insurance companies, the pharma companies, the hospitals, they're kind of sticking with the status quo. They're familiar with it. Many of them are making a lot of money at it. So it's going to take some push. The change that we need is not going to be welcome among many of the incumbents. And so we also need a public voice. I think we need an activated public. And if I could wave a wand and get that done, I would do it.
All right. I think you're not alone. And I guess that brings us to sort of your vision with the paper, which you start with the simple line, this is a vision for a new health system. But then you go on to outline a series of pretty comprehensive goals. I'll run through them really quickly. Affordable, accessible, equitable care for everyone, protecting Americans from unsustainable costs, adding a decade of healthy birthdays past retirement age, eliminating disparities, improving outcomes, and reducing total U.S. health expenditures. To be honest, these all seem kind of obvious to me. But then again, no one asked me to boil down the last 40 years of health reform. So I'm curious to hear from you. How easy was that first step, or how hard was it? And really, why is it important to start there?
Well, yeah, you're absolutely right. They are obvious, and they become even more obvious in light of multinational comparisons. Part of what motivates this is looking at health systems around the world and seeing how much better they are, how much better they perform on every single one of those goals that you just stated. But the problem here is that we seem to be in a mode in this country of, I guess, what I'll call kind of tongue-in-cheek admiring the problem. I mean, we've known that we have inequities in health status by wealth and race. We've known that for decades. We've known that our healthy lifespan lags those of other wealthy nations by 5, 6, or 7 years of healthy life. We know that our costs are crazy from the viewpoint of comparison to other countries. Not only is our system underperforming, but we're paying twice as much as any other country per capita to have the underperformance. So you're absolutely right, Rob. These are not surprises. But what I would say is they're also not aims yet. And that's the key here. Not that this is new knowledge, but the call here is for a commitment, a national commitment, whatever that can mean, to end these defects. That's what we don't have. Why? Well, we're very fragmented. Every one of those goals has political aspects to it where the changes would be unwelcome politically. There are incumbent stakeholders, as I said, who are making a lot of money in that defective status quo, and they don't want to give up that profit. And we don't also have mechanisms for national agendas. We do in wartime. We want to come together to defeat an enemy. We did in COVID when, with a lot of hiccups and really tragic errors, we nonetheless came together as a nation and said, we're going to beat this virus, and we did. An example was the production of the vaccine, breathtaking pace and scientific excellence in getting to the vaccines, which worked and saved not enough lives, but a lot of lives. But with respect to healthcare reform, the new system, who's accountable? Who steps up and say, all right, I will make that happen, or we will make that happen? The answer is no one has. No one. And the question is, can we? In countries that have, say, a minister of health, where the political machinery points to that office and says, we have an opioid epidemic, substance use disorder epidemic, you, minister of health, you hold the bag. You will change that. What do you need to get that done? We don't have such a mechanism in the United States. We do in some arenas when we decided, obviously to get to the moon, and we did that. We set up an entity to do that. We've done pretty well on clean air. And that was because statute was passed, there was an accountable authority, and goals were set. But with respect to a reformed healthcare system, no.
So the rest of the paper, you really dig in and make some specific recommendations. They're structured around 8 key principles. And as a reader, I appreciate how explicit the paper is about which recommendations are meant to advance which principles. We obviously don't have time to walk through all 8, and I want to encourage our listeners to read through the full article to get the full scope. But I did want to pick a few to explore. Principle 1 is basically affordable access to comprehensive coverage and care. And I noted that the very first recommendation is not about specifics of coverage, Medicare, Medicaid, you get to that later. Instead, you start by proposing the elimination of medical debt and say that Congress should prohibit debt collection from any household with a gross income less than 400% of the federal poverty level. Why start there?
Because that's what's going on at the kitchen table. The one of the only answers we're able to come up to as a group of authors about how to get the kind of changes we needed is to mobilize, or I'd say connect to public sentiment. So we what's going on at the kitchen table today? Well, we know American families around healthcare are currently focused on 3 conditions in their lives. One is cost. They're just paying more and more out of pocket for their drugs, for their copayments, deductibles, premium levels, taxes. So if we don't address cost, we are kind of tone deaf. We're missing what a great deal of the American public is concerned about. And that's not just people in poverty. They're people experiencing poverty. That is a problem right in the middle class table as well. In my state, Massachusetts, a very expensive state, the cost of a family coverage in Massachusetts has gone up now to about the cost of a car. It's not sustainable. One form that takes is about over 100 million Americans who have medical debt. That's not true in any other country in the world. No other country in the world, no developed country, no wealthy country can make that statement. So we went right to the heart of that matter and said it isn't okay. It has to stop. And I think especially with people, at or slightly above the poverty line, this 400%, it's crazy. It's crazy to say to get the health care, you have to go into debt. In too many cases, lose your house. And in far too many cases, face bankruptcy. So we want to tune in to where the public is. To say we have to control costs without attention to the other things, the public is also concerned about 2 other things right now. One is cost. The second is access, that I can't get to a doctor. I can't find a primary care doctor. The waiting time for my appointment with the orthopedist is 4 months. So they're really concerned about access right now. And the third is a vaguer concept, but real, which is complexity. I don't understand. I get this piece of mail from my insurance company. I don't even know what it is. It says it's not a bill, but what is it? How come I can't get into the consultant's office, for 4 months or worse? And then when I stand in the line at the pharmacy and then pull out my credit card, it's like playing roulette. I have no idea what that number is going to be. And once they give me the number, $90 right now, Mrs. Jones, I don't know where the number came from. Coverage, where I my doctor says I need this procedure, but the insurance company won't approve it right now. Well, why not? What does insurance mean? So this sense of opacity and complexity is there. And hopefully in our recommendations, we are trying to go right at that and not just look at it from the health policy wonk's point of view.
Great. Well, that's just one recommendation of many. We're going to take a pause, and when we come back, we'll talk about a few more. And we're back. I'm here with Dr. Donald Berwick talking about his recent paper as part of the National Academy of Medicine's Vital Directions series. Dr. Berwick, for the most part, the article is focused purely on the U.S. healthcare system. But in one spot, Principle 2 focused on elevating integrated primary care. The paper does point to two other countries, Costa Rica and I think Australia, is providing models that we in the U.S. might consider learning from. And I was curious if there's something about primary care in particular and integration where it makes more sense to look abroad than it would, say, for some of the other principles.
I think we can learn lessons from abroad in almost every principle. There's no perfect system in the world. Every country is struggling with healthcare, but when you pick a topic like primary care, you're going to find some pretty interesting examples outside the U.S. I want to sort of have to go back to the basics. The basics here are we need goals in this country. We're not living as long as people in other countries. We're not as healthy when we have chronic illness. Our kids aren't doing as well. So we need a goal. Like one of them is extend healthy years of life by 10 years, by a decade, by a defined period of time. How? How do you produce health? What does it look like? Strangely, we know. The research is absolutely clear about how you produce health. You focus on the needs of young children. You have a strong education system. You make workplaces safe and protective of workers and places where people can be proud of their work. You have systems to support elders so that they can be connected socially to communities. And you have communities with strong infrastructures like food security, housing security, transportation security, criminal justice that is really healing, and so on. So we absolutely know that the data are there. We could add 10 years of life if we acted on those. Notice, healthcare is not on that list. Mm-hmm. That in fact, healthcare's leverage on health is not terrific. It's there. I mean, if you have a heart attack, we know what to do, and we can extend your life. But most of the benefit in life extension, which is among our goals in our paper, don't lie just in the healthcare system. So where in healthcare can we get some traction? The answer is primary care, where you first meet the system. That doctor or nurse or physician's assistant who's seeing you has a repertoire of resources they could bring to bear with you. If you're food insecure, they can help you with that. If you're depressed, they could get you into the mental health care that will get you not depressed. If you're lonely, they will have ways to help with loneliness, as well as giving you the right medication. So primary care is a fulcrum for the pursuit of health in every successful healthcare system in the world. We point to Costa Rica and some of Australian experience as just one of many, many examples we could show where strengthening that component of the healthcare world is a much better route to health. In the U.S., we didn't do that. We have, I think, a terrific healthcare workforce, but we've understressed primary care and understressed social care, community supports, because we're way spending our money excessively on very high tech, very expensive, and very high priced procedures and hospitals. We need hospitals. I don't want to say we don't. And if I need an organ transplant, by all means, make sure I get one. But we're going to have to reallocate energies to be able to get the health we want. Total cost would fall in the longer run. Total cost would fall. And that's why one of our other goals is to get our total cost structure in line with OECD countries, the wealthy, mostly Western European countries that are spending, maybe 10, 11, 12% of their GDP on healthcare instead of our 17 or 18% and getting better results.
So I wish we had time to cover all of the specific recommendations in the paper. But before we move on, I wondered if there were any specific ones that you're particularly excited about or something you want to make sure folks don't miss out on.
I care about every one of those recommendations that was carefully put together, and we probably missed some important things. I think that I want to emphasize the importance of shared American goals for health, which we do not at the moment have. I think there are recommendations that bear on strengthening primary care that are crucial that you've just talked about. There's a recommendation on accountability. Like, where does the buck stop? There's no buck stoppage with respect to what we're talking about. And we're kind of talking about a much more transparent system and actually setting up a supervisory board of some form, maybe equivalent to to what we do in finance in this country, just to say oversee, at least report back on how we're doing and have some sense of responsibility. Among the things people might miss, there's a very important set of recommendations on Medicaid. Now, that's a little bit in the weeds here, but let me explain. The American safety net health care system is Medicaid. It's very important. It helps as many people as Medicare does, but for certain political reasons, it generally doesn't occupy the center of the screen, and a large amount of the responsibility lies with the states. At the current way Medicaid's set up, and certainly if the current administration proceeds with its apparent intentions to cut further, Medicaid's way underfunded. And so we're proposing bringing Medicaid payments up to Medicare levels. That's a big ask. It costs money. So we have to find savings elsewhere.
Yeah.
But if we don't do it, we're going to miss an awful lot of the population that's in pretty rough shape right now. Some way to focus more on social determinants of health. So we have ways to get resources to what's actually making people healthy. One big question in the paper that we leave unanswered is the role of markets versus government action. We have a whole bunch of activities based on the idea that if markets would work in healthcare, things would get better. That's how cars get better. That's how computers get better. Others say, no, it's more like a public good. And like we don't really rely on markets for our fire departments and our education and other high-performing parts of our systems. And healthcare is more like that, where we need much more muscular government action to protect people's health. That's a controversy that continues. I certainly am more on I think we need collective action here. We need government action, more muscular, and much more constraint on the profiteering that we're seeing in healthcare, which is one of the reasons our costs are so high.
So this isn't your first health affairs article, of course. Among many others that you were the lead author of, included an article published in May of 2008 titled The Triple Aim, Care, Health, and Cost, in which you outline your theory that fixing healthcare in the U.S. requires a simultaneous pursuit of improving patient experience, improving population health, and reducing per capita costs of care. Now, here we are nearly 17 years later, and this concept has really become as close to universally embraced, I think, as anything in our field ever has. And I wanted to know if that surprises you, or if really knowing what you know from the last 17 years, if you would have changed anything about how you framed or approached that discussion.
Well, first, I have to give credit where credit is due. I wrote the coattails in that article with my two co-authors, John Whittington and Tom Nolan. They were the inventors of the triple aim concept. What they were trying to figure out is an efficient way to describe the purpose and quality of the healthcare system. And these three big pots: better experience of care, that's safe, effective, patient-centered, timely, efficient, equitable care. Like if you need surgery, it's going to go okay. Better health in the population, that relates to the causes of health that I just recited, and at lower per capita cost. That's the triple aim. Better care if you're an individual, better health for populations, lower per capita cost. I still believe that that's a really powerful framing, and Whittington and Nolan nailed it. And you're right, it's been picked up. It is mapped now into the healthcare strategies and policies of entire nations around the world. It's a very important concept. Many of my colleagues would criticize us for not emphasizing more equity. That we probably should have had a for everyone. Maybe we did. I don't remember the paper in much detail, but we leave people out, and that's okay. My colleague Kate Armate said that without equity, there is no quality. You can't take credit till everybody is included. So perhaps that was a little short-sighted in 2008 when that paper came out. I still think it's right. And I still think it's a matter of optimism to be able to put them all together on the same screen. This is not a trade-off. It's a collection of synergistic efforts. If we had a healthier population, then our care quality would go up because we'd be able to focus energies on fewer people who are getting sick. Our costs would go down because there'd be less need. If we reduced waste in healthcare, our care systems would be more efficient, but better to be in. You know, my wife went to the emergency room recently and waited 8 hours for a simple prescription of antibiotics. That's waste and raises costs and is a terrible experience for the individual and takes risks with her health. So I still think it's right, the triple aim, better care for individuals, better health for populations, lower per capita cost. But that always gets back to the how, thumping the table and saying, deliver that isn't helpful. It's describe then a system that can do that. And that's what our paper tried to do in the Vital Direction series.
Well, I'm glad you used the word optimism in describing the triple aim, and it brings me back to the introduction of this paper, the Vital Directions paper, which begins. There's a section that begins with these words. You say, "We recognize that transforming an industry that accounts for 1/6 of the U.S. economy will face enormous political headwinds." And you go on basically to outline those headwinds. They're pretty serious. And I think including that was probably essential to maintaining the credibility in this moment and acknowledgement of reality in your paper. But I think it also sort of creates a tension between the aspirational nature of this project and maybe some of the harsh truths about how far we have to go in this moment. And so I'm curious what you would say to a reader who might be feeling that tension and is maybe struggling between how to read your paper through a pessimistic lens or an optimistic one. What do you recommend?
Well, you absolutely nailed it, Rob. That's exactly the tension that's inside that paper. Look, we have a problem. American healthcare is far too expensive. It's taking resources that are badly needed elsewhere from individuals, from governments, from private corporations, and it's not delivering. Our health is declining and bad. We're unable to recruit the intention and energy as a nation to solve crucial problems like the epidemic of substance use disorder and opioid use disorder. We know what we could do. We could stop those epidemics. We have the science now to at least dramatically reduce the tens of thousands of deaths that come from those problems. We have children whose health status is ranked the lowest of 17 nations in the OECD. We have elders who are lonely. Look, it isn't working. It isn't working. So now optimism or pessimism. Could it work? Could we imagine a system that produces what we need? Absolutely yes. Absolutely yes. That science is well in hand. Lower cost, higher quality, better health. The problem is that the current system has powerful interests that are doing well in it. They're not the majority of us. They're not even close to the majority of us, but they're very, very powerful. So this means that healthcare reform will have to be in some crucial level political. We're going to have to come to terms as a nation with the failure, and the public will have to hold all of ourselves accountable for a new system. Can that happen? I don't know. There's so much misinformation, so much misunderstanding. I don't know, but an informed public that really wanted health in our nation could create the political force to make it happen. In little ways, we're seeing that. Maybe that start right now at a bipartisan level. We're hearing both sides of the aisle this kind of concern about drug costs that says, no, it's going to stop. We're going to end it. Finally, in this nation, where we've given Medicare the chance to negotiate drug prices. That sounds like a small step, but it's a rather big step. Medicare, under the Biden administration, began to provide coverage for some kinds of social services and home health care that it never did before. That's changed. So little steps we're starting to see, but we need a gale force public sentiment now to say enough is enough. We can't afford it the way it is, and it's got to change. I don't know if we'll recruit the energies to do it, but nobody anymore can say we don't know what the designs look like. We do.
We shall see a great prescription, perhaps, for the healthcare system going forward. Thank you so much, Dr. Berwick, for your time, for your service to health and healthcare in America, and for joining us today on A Health Podyssey.
Thank you, Rob. Anytime. And thank you for bringing these matters to the attention of a wider audience. That's absolutely necessary.
Thank you. And to our listeners, thanks again for joining us on A Health Podyssey. If you enjoyed it, please share it with a friend and tune in again next week.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.